Dr. Ruchika Fernandopoulos, Chief Executive Officer, Co-Founder, Iora Health. Welcome to Juicing with Gary.
Thank you. It's great to be here.
Oh, it's an honor to have you here. Pleasure. Now, do you love juice?
I love juice.
Well, hopefully you know how to juice.
I've done it maybe once or twice.
Okay, well, this will be your third or fourth time. How
Good.
about that? Okay, so did you ever hear the singer Fats Domino?
Yes.
And you remember he had some great hits in the 50s?
Blueberry Hill.
So this is called Blueberry Hill in your honor. So
Great.
we're going to use the beautiful blueberry
today,
along with all these other berries to make our juice and then have our conversation. So with that said, I need you to help me.
Okay.
Now I'd like you to take the beautiful pear
Okay. Beautiful pear.
and then the beautiful apple.
Yes.
And I'd love you to just slice them in half.
Okay. That we can do.
Just
Use the
pack
big
it
knife.
right down there. Now be very careful. These are very sharp and our liability insurance is not all that great.
All right.
Ready to go?
I'm ready.
Okay, let's get her juice them. All right, just stick them right down in there. Oh, and you'll see this is such a beautiful. Oh, this is it's a little sloppy. That's okay. That's all right. Now, my favorite, because I grew up on a farm, is the red raspberry. So just pour them right down in there. Help yourself. Put them in there. Just make them go. Woo! Just perfect.
Beautiful.
And my good doctor, we have juice. Now, what we're gonna do is I'm gonna give you the official stir.
Stir.
Oh, look at this. Did you do that on purpose? You put blueberries in our glasses. That was very,
little
very
garnish.
good. Yeah, a little garnish. Okay. Well, doctor,
Cheers.
thank you for being here today.
very
Look
welcome.
forward to the conversation.
Sounds great. Thank you.
To your health.
It's
Right?
good.
It is good.
Yes.
Yeah, what, you think it was gonna be bad? Come on. I'm a juicer.
Thank you.
Well, Ruchika, thanks for being here. This is really exciting. Did you enjoy the juicing?
I did. I'm going to make me go home and pull our juicer out of our attic and get it fired up again.
I'd love to turn the conversation around and talk about a few things. First of all, I want to talk about you. And eventually we'll get into Iora Health and how important that is and some of the good work you and your colleagues are doing. But right now, I'd love to know who you are.
Sure. So I was born in a place called Sri Lanka, which probably not a lot of people have heard of. It's a little island off the tip of India. We moved here when I was about 3 years old, sort of the late 60s. My dad was a doctor in Sri Lanka and had always wanted to do psychiatry, but there was no psychiatry training programs there. And so he got an opportunity to come to Hopkins and do a psychiatry training program. So we all came over. It was meant to be a 4-year thing, and then he'd go back. But then there was a little ethnic war that started in Sri Lanka, so we decided to stay a few more years, and now it's been almost 50. So growing up, I think with a dad as a doc, I've always sort of contemplated being a doctor. But I found I was also really interested in system issues. I was a government major here at Harvard, studied ethnic conflicts in Sri Lanka and Northern Ireland. And so I was torn at the end of college as things were rolling up, whether I wanted to try and go to medical school, and I'd done all my pre-med requirements on the side, or if I wanted to go into consulting or business. And I remember there's a moment where it actually was clear to me. I'd gone to one of these receptions that one of these big consulting companies had over at the Charles Hotel, where they serve you the little potatoes with the caviar on it. And the pitch was, if you come work here in this brand name consulting company, you only have to work with smart Ivy League educated people. And then right after that, I was going home for the weekend, so I caught a flight down to Baltimore, Maryland, where I lived. And as I got home, my mom said, welcome home. And by the way, can you run over to our neighbor's house to borrow some sugar or something for the dinner? So I went over, and our neighbor was this elderly Italian woman who did not have much education. They had moved to this country too. Husband was a tailor, started his own tailor shop, and they had built it up. They were doing fairly well. And just sitting at her table while she was getting the sugar, talking about her life in Italy, and I realized, wait a second, I actually like interacting with people who are not smart, Ivy League educated. And I think going into medicine will allow me to do that in a way that going into these other sort of business sort of things wouldn't. And so that was when I made a decision. I am going to make my application to medical school and go in.
I'm so happy that your mom asked you to go get sugar. No, truly, because as I have been in healthcare a long time, not at the professional level you have by any means, I have seen the brokenness and I've seen the opportunity. So what I'd like to do is start to transition slightly and talk a little bit about Iora Health. And I'm really interested in how it developed, what it might look like. But first I want to know, what's with the name Iora? What does that mean?
So an Iora is a little bird from Sri Lanka, which is where I was originally from. I was trying to find a name that didn't actually mean anything to a lot of people. I was sort of tired of the health quality partners in quality health, yawn. So I wanted to pick a name that was short, easy to remember, that didn't have any meaning that people already imbued to it, that it was something we could put meaning into.
I think it's a beautiful name because, as you said, yawn, everything is around health, and that's fine in many ways, but to make it more personal, something lovely like that. So I'll have to look that bird up.
Yeah, and we use a lot of actually bird-themed names around the company. So our main office in Boston is called the Nest. Not the head office, but the Nest. It's got a nice, warm feel to it. We've built our own IT platform, which we call Chirp, because it's a collaborative care platform. It's all about communication, not about documentation and legal mumbo jumbo. So we've used the bird theme in a number of things.
Tell me about Iora. Tell me about the organizational structure. So what, quite frankly, do you deliver and do you do? And who is the customer?
So the point of Iora Health is to really build a vision of where healthcare ought to be. Our ambition is no less than transforming all of healthcare. And the way to do it is not by talking about it, not by studying it, but actually do it. Let's build a vision of care that we ought to have. Let's get patients to vote with their feet, and let's sort of dare the rest of the system that they need to keep up with it. We're a new entrant here, right? We're not consulting to existing providers. We're not, building a little piece of the system. We're saying, let's just rebuild the whole system from the bottom up, geared around what we think it ought to be like. Our tagline is restoring humanity to healthcare, because that's really what we need to do. And what we realize is to do that, we have to start over and align everything. So what we do is we say build bottom up, start with the consumer, or the person actually is maybe the best word. Not patient, maybe not even consumer, but the person, and build up from them, not down from the health system or the big health plan. The best anchor for this is actually primary care. And why is that? Because primary care can obviously help people with what most people think of primary care, which is taking care of acute conditions and maybe helping you manage chronic conditions. But done right, it allows you to manage what I call the upstream, which is teaching people to eat better and exercise more and reduce stress and figure out social connection, deal with social determinants of health, and we can help people with the downstream. So even no matter how well we do, people still need to see specialists or go to the hospital. We can help them navigate that system. So primary care is this great fulcrum point. If we fix primary care, we can help rationalize the whole system.
So let's stay on that. So the physicians must be loving this. So how does a physician become part of this? How do you find the primary care physician?
So if we want to rebuild the system, the first thing we actually have to change is the payment model. So I think part of the original sin of American healthcare right now is the fee-for-service payment system, particularly for primary care, which pays you per doctor sick visit. And that's basically all you get paid for, doctor sick visits. So much of the right thing to do, you don't get paid for. And then it focuses you on these transactions. So it's turned healthcare into a series of transactions: document, code, bill, next. Right? Doctors, you walk in the door in the morning, you have 38 patients booked, see them as short of time as you can, bill as high as you can, turn your brain off, move to the next person. Last time I checked, transactions have never healed anyone. Right? The things that heals people is relationship. And so the whole idea is we need to change the system to be based on relationships. So first we have to get rid of this payment system, right? Now, a lot of the people who talk about value-based care, they say that word, but they mean fee-for-service, and they give you a little bit of bonus on top of it. One of my favorite quotes is from Michelangelo. Someone asked him, how did you make the Pieta, this beautiful sculpture in Florence? He says, well, it's really simple. I take a block of stone and I chip away everything that's not the Pieta. Right? So I think for us to fix healthcare, what almost everyone else is doing is adding more stuff onto the current system. And our insight was maybe we should take stuff away.
So how do we solve all of this?
Yeah, so we solve it, like I said, by starting from scratch and building a new model from the ground up that's centered around actually improving people's health and not about doing more stuff to people. So as I said, we start with a payment model that's different, that allows us to do this. By the way, this is all we do in our practice. What a lot of people are doing is taking existing practices who are doing fee-for-service and trying to crank up more RVUs and more tests and saying, for these 10% of patients, I want you to treat them somehow differently and actually improve their health. But these other people, we actually don't care about that. That's really, really hard. So all we do is this. We start from scratch. We hire people who want to do this. We don't hire people who don't want to do this. We build systems in order to do this. We don't use systems that don't do this, right? So I think it's aligning everything. So we build these teams to try and engage people, doctors, these health coaches whose job it is to help people implement their care. We embed mental health into the practices with behavioral health specialists. We focus on social work and social services to help people with other social barriers to getting the right care. If we need to do therapy, if we need to do other things, really building very robust teams around people. So again, we start each day in the practice with a huddle. For 45 minutes, everyone sits around the table on the team and talks about our patients. So not necessarily the people coming in, we talk about that for a little while, but the more important thing is we talk about the people who are not coming in, who we think that we're worried about, that we ought to be proactively reaching out to. Again, if you think about most medical practices, what you do, you sit in your office and you wait for people to walk in the door. If you are responsible for a population, that's the stupidest thing you can do. Because the people getting into trouble aren't the people coming in today. The people who are not coming in today, sitting on their couch, eating their Doritos, not taking their medicine, right? So we need to know who they are, and we need to reach out to them.
So this is truly managing the health of a population. This is what population health management is all about.
It is. So we think population health should be core, and it should be our job as doctors, not to be left to some health plan with a nurse in Idaho trying to call our people at dinner time. That's completely ineffective, right? We are doing population health from the practice with the real clinical data, with the real relationship with the patient, because this is all in the end about behavior change, and with an effector arm that we can actually change therapy. Our teams are taught, your job is to, again, help people with their life that'll improve their health, and do whatever it takes. So we, the coaches, the doctors, we have social work folks in practices, really focus on what are the barriers to people getting healthy, and how do we fix that? So that could include rides. So a while ago, we realized that often transportation is a barrier. So we have a partnership through a company called Circulation, which actually works with Lyft and other ride-sharing services, actually order rides for people to bring them in. In some of our practices where people are food insecure, we actually partner with a food bank and actually distribute food from within the practice. There are places where we have clothes that we can give people. Really, I think it's do whatever it takes. We have lots of stories, I think, where people do this. One of my favorites is we had a patient, an elderly gentleman who had hypertension and diabetes who ended up on dialysis. And so ended up 3 days a week having to go to the dialysis center, plugged in. But every now and then he also had an anxiety disorder. He'd say, I need to get up, I gotta move, take me off of this. So they'd unplug him. And he goes home. Now he didn't get dialyzed. So what happens the next day? He shows up in the emergency room in renal failure. And so they admitted him to the hospital, 2 days of inpatient dialysis. On the way home, they say, give him an Ativan tablet, anti-anxiety tablet. He hates it, throws it out on the way home. The last year, 13 times this cycle happened. $200,000 of healthcare costs. The system didn't do anything about it. Came to our practice, health coach, hired for empathy, really said, Mr. Edwin, this must be awful. He said, yes, it is. I feel awful. Does this ever happen other times? Oh, sometimes at home, I feel I have to get up and move. Key question is, at home, is there anything you can do to fix it? He said, at home, I put my music on. It calms me down. So she comes out, and we give our health coaches a budget to spend on patients for anything. She said, Doc, can we buy one of these iPod thingies? I was like, absolutely. We go online, use iPod Shuffle, $35. What sort of music do you like? He likes merengue. Well, tell the other girls to bring their merengue CDs and block an hour out to download the merengue onto this iPod. She does. Next week, he comes back in. I say, everyone, stop what you're doing. We all go to his room. Congratulations, Mr. Edwin. You win our Patient of the Month award. We, of course, don't have a such thing, but I need an excuse to give him this thing. Here's your prize. Oh, this is great. Put it in, press it, play. Oh, my favorite song. Great. Every time you go to dialysis, I want you to take this, listen to the music, and think of us. Next 6 months, 0 admissions. So we just solved $200,000 of healthcare costs, huge human costs for this poor guy, with a $35 iPod. Why does no one do that? They think their job is do what you're paid for, do what the billing code says. There is no billing code for buy iPod on eBay. There's no billing code for download merengue onto said iPod, right? We don't ask that question. We ask the question, do what it takes to solve the patient's problem, even if it means buying them an iPod.
You're digging at the root cause in the best single example that I think I've ever heard in my entire career. Because you're doing what the research has told us for over 50 years, which is more than 65% of what creates health isn't what I eat, it isn't whether I exercise, and it isn't just my genetic code. They play a role. Where I live, whether I have a car, whether I have relationships, whether my boss is a jerk and treats me poorly at work.
Yes.
These are things that influence health. And by having coaches, by having physicians, by having a team that can huddle together to come up with something as simple as a $35 iPod to save $200,000 in annual spend, well, that's flipping the system. And that's the way we should do this.
It is. So again, we take care of a lot of seniors. The research more and more is saying the thing that influence your health and longevity have nothing to do with healthcare. It has to do with what's called personal determinants of health. This is Charlotte Yeh, AARP. It's sense of optimism, sense of purpose, and connection. Right? If you look at the Blue Zone research around the world, that's what actually matters. And so we say, let's actually spend our time doing that. And yes, we should prescribe the meds, and yes, we should do the primary care. But that's the little part. The big part is this engagement with human beings.
So it is an absolute honor to hear this story, to see the vision, the architecture, and we're just excited to be able to participate with you and certainly come alongside and where we can help. And I hope others will join us in sharing this message, this important message of the work you're doing.
Great. Well, thank you very much for having me.
Well, it has been my honor.
Thank you.
Thank you for being here, Doctor.
Here's the
Best
juice.
of wishes.
Thank
Cheers.
you.